everyone, and welcome to today's PHO Rounds presentation on building a national health data system for perinatal opioid exposure, a collaborative approach. My name is Sarah Carsley. I'm an applied public health science specialist here at PHO, and I have the pleasure of moderating today's session. Before we begin, I would like to acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I'm in Toronto on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys, and worldviews. May their wisdom always guide our own paths forwards with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. It is now my pleasure to introduce the speakers for today's presentation. Andi Camden is an epidemiologist and senior research associate at the Edwin S. H. Leong Center for Healthy Children at SickKids, as well as an ICES fellow. Her research uses administrative data to explore the impact of opioids in pregnancy on maternal and child health across the life course. She leads the Canadian Perinatal Opioid Project, an initiative funded by the Public Health Agency of Canada that aims to establish a pan-Canadian health data system to monitor perinatal opioid use and health outcomes. Ashley Smoke is a Two-Spirit First Nations person from Alderville First Nation. They are a team lead, knowledge translator, community-based researcher, and cultural support, among other things, with deep roots in harm reduction, Indigenous health, and systems change. Ashley currently coordinates and facilitates workshops for incarcerated people across Canada and serves as team lead for a national facilitation team. They offer engagement, support, and services to many organizations looking to engage with the community in a meaningful way. Welcome, Andi and Ashley, and I'll now pass it over to Andi.
Thanks, Sarah, and thank you to PHO for having us here today. We're really excited to share a project with you that we've been working on called the Canadian Perinatal Opioid Project. So today our presentation is called Building a National Health Data System for Perinatal Opioid Exposure, a Collaborative Approach. So this is a project that I'm currently leading along with Drs. Astrid Gutman and Hilary Brown. Next slide, please. So we just have a couple disclosures. Here's the PHO one. And next slide. So this project is supported by the Public Health Agency of Canada. I don't have any disclosures to disclose. Ashley Smoke is a member of several advisory groups and receives payment for consulting activities. Next slide, please. So today our learning objectives are to describe the role of the Canadian Perinatal Opioid Project in strengthening surveillance of perinatal opioid exposure, including our project's key goals and outcomes. We'll also summarize the different engagement strategies that we've used when developing this project. And then lastly, we'll talk about how to locate and use surveillance data that's featured on the Canadian Perinatal Opioid Project dashboard in public health practice. Next slide, please. Oh, I'm going to pass it to Ashley to provide background.
So first I'll talk about just opioids in general. They're a class of drugs that act on the body's opioid receptors to reduce pain. They can be naturally derived from the opium poppy, like morphine. They can be semi-synthetic or fully synthetic. There are different types and different uses for opioids. So like sometimes people who use drugs might need opioid agonist therapy, which is used, or OAT, which is used to treat opioid use disorder. Some of the common medications might be like methadone, buprenorphine, slow release oral morphine. And the goal is really to stabilize people, reduce their cravings, withdrawal symptoms, and allow them to just function in their lives without using unregulated or street drugs or heroin or whatever they were on in the first place. There's also like people also have opiates for prescriptions for pain management, either for short or they either have short or long-term pain relief needs. So like after surgeries or injuries, for chronic pain, for cancer and other ailments. So there's also unregulated opioids like fentanyl, which could be illicitly manufactured or not. Carfentanil, heroin, and other mixtures of different opioids and analogs that have come into the supply. Unregulated drugs or the street supply often contain unpredictable and highly potent synthetic opiates, making them extremely dangerous. So yeah, fentanyl and other street opioids have been really the cause of a lot of fatal overdoses for people who use drugs. And now they're mixed with benzodiazepines, which increases toxicity and overdose risks. So basically, pregnant women are just like other people who use drugs. There's a rise in opioid use, including like especially because of the toxic drug supply. So this is actually reflecting deeper issues systemically, like trauma, inequality, lack of access to safe care, criminalization, stigma, etc. So pregnant women are just like everyone else. Pregnant women take opioids just like, you know, people who have injuries or ailments that they need to take opiates with. So when I did a lot of the interviews that we'll talk about, women were taking opioids for migraines, for injuries they sustained, car accidents, other things that really aren't necessarily preventable, and there was a need for opioids to be taken. So there's like a moral dichotomy where pregnant women are assumed to not have to take opiates or shouldn't be taking opiates because of the moral implications. However, that's not necessarily the case in the research that I've done. I've talked to many pregnant women, and a lot of them take opioids for various things, including OAT and that kind of thing. So these increases in use among pregnant people lead to increases in children with prenatal opioid exposure. And that's something that's been really stigmatized. My own experience is like I started doing this work because I was stigmatized in the hospital because I was on OAT. And I think there's not enough education and information out there for the public around like the need to take OAT while pregnant and actually increase it later on, and like the way that children are treated in the hospital and how neonatal abstinence syndrome is treated. So yeah, I think there's a lot of different educational things, and my own experience has led me to to do this work and advocate for these things. But that was just some background on like how opioids are used and why the use is increasing, and the issues that are arising because children are being born with prenatal opioid exposure. And this is leading to lots of different things like developmental issues and other things that we'll see later on. Next slide.
Great, thanks, Ashley. So we started investigating prenatal opioid exposure in Ontario during my PhD, and it was through this work that we really identified several different knowledge gaps and also practice gaps, which really formed the basis for this project. So as Ashley had noted, we had seen increases in opioid use among pregnant people and increases in prenatal opioid exposure in children. But we didn't really see a lot of evidence on the impact of opioid use and what the trends looked like in Canada. So it probably goes without saying, but there also weren't any federal or provincial surveillance programs that were monitoring perinatal opioid use and opioid-related harms in Canadians, and nor were there federal or provincial guidelines that were supporting the health of pregnant people and their children beyond the neonatal period. So of course, you can see a lot of clinical practice guidelines that really cover pregnancy or the time spent in hospital, especially for neonatal abstinence syndrome. But once people leave that birth hospitalization, there really isn't a lot of guidance as to what should be happening. So this was really the impetus for this project. And I just want to mention, next slide, please, that a couple things about neonatal abstinence syndrome. So I know some of the public health units in Ontario do report on neonatal abstinence syndrome, and I think it's a really important indicator for a number of reasons, but it can be used in several different ways. So sometimes it's used as a surveillance indicator, so it can tell you a lot about different healthcare needs, but some people use it as a proxy for prenatal opioid exposure because it's typically easier to access and it's more readily available. And reporting on neonatal abstinence syndrome doesn't require the maternal-infant linkage in administrative data. But in my first PhD paper, we explored methods to identify prenatal opioid exposure in administrative data in Ontario. And one of our key findings was that if you look at NAS alone as an indicator, it only identified about 45% of prenatal exposure, prenatal opioid exposure. So that means if it's used as a proxy, that you're really going to underestimate the true prevalence. And also to add, we also see health complications among children with prenatal opioid exposure who had NAS and who didn't. So I think it's important that we're thinking about this broader context and looking at prenatal opioid exposure. Secondly, sometimes NAS is framed as a negative indicator. So I think having the data on the source of exposure is really important because the situation of a newborn experiencing withdrawal from, say, fentanyl on the street is quite different than a parent being in treatment for OAT and then an infant developing withdrawal. Third, it can really be a biased indicator. I think if healthcare providers are aware of substance use or they're stigmatizing people, it can lead to medical surveillance bias. And so infants tend to be monitored closer. And then lastly, there's more of a focus now on non-pharmacologic approaches like eat, sleep, console. And this may affect the severity of NAS symptoms and the diagnosis. So it is an important indicator. It does have some nuances that I think are important to be aware of. Next slide, please. So we developed the Canadian Perinatal Opioid Project, and it really has two main objectives. The first is that in collaboration with community-based advisory groups, our goal is to develop a national surveillance system to monitor perinatal opioid use and to investigate the impacts of perinatal opioid use. And then using this surveillance system, we have several research objectives that we're interested in, from looking at the epidemiology in Canada, doing some provincial comparisons. We're also interested in looking at the intersection of different social determinants of health, and then examining some health complications, both maternal and child health outcomes, and then being able to look at some of the longer-term child health outcomes. So things like developmental health, preventive care, eye disorders. Yeah, and then if you can click the next button. Yeah, so essentially what we've done is we've created a bit of a different cohort studies in the different provinces. So what we're doing is we're ascertaining prenatal opioid exposure from prescription opioid records, outpatient physician visits, and maternal and newborn hospital records. And then we are following people through pregnancy and the first year after pregnancy. And then for children, we're following them up to the age 8. And of course, this will increase with time as well. And then our overall goal is really to use the information that's generated from this project to inform supports to improve the health and well-being of pregnant people and parents who take opioids and their children. Next slide, please. So as the name suggests, we do have a national focus. And we have 5 provinces involved in the project right now. So BC, Alberta, Saskatchewan, Manitoba, and Ontario. And in every province, we have a co-investigator who's affiliated with the university and the data repository in that province. For Ontario, we are using ICS data. As I mentioned, this is a project that's co-led by Dr. Hilary Brown and Dr. Astrid Gutman. We also have Dr. Tara Gomes on our team, and Ashley is part of our team as a peer researcher. And then we have Reshma and Ali, who are just at the top, and they support the entire project. So they're the research coordinators on this team. So our hope is to eventually expand to include all provinces and territories. These 5 provinces were specifically chosen because they all have administrative data that includes a linkage to prescription opioid records, and they also have the maternal newborn linkage as well, so that we can identify the dyads. And we recently published our methods in a protocol paper in BMJ Open that's here in case you'd like more information. Next slide, please. Okay, so we have tried our best to make sure that this is a community-driven project. We have a number of different engagement activities, and because there's such a range of audiences that we are focused on with this project, we've tried to use several different engagement activities and have several different knowledge translation activities. So one of those is working with a peer researcher. So Ashley's on our team. We also have fantastic provincial and national collaborators across the country. We've developed 2 different advisory groups. Our surveillance indicators were all determined through consensus methods that Ashley and I will talk about a little later. And then we've also been working on a really fun storytelling project to be able to highlight the people behind the numbers. As I mentioned, we do have several research objectives, and we will be engaging with people with lived experience and knowledge users throughout the research process. And then lastly, we have a number of different knowledge translation activities that we've planned. Some of these will be co-developed, and most of them we still bring back to our advisory groups. So one of the main ones is a dashboard that we'll be talking about a little later. And I am going to pass it to Ashley to talk about some of these activities in a little more detail.
As a peer researcher, I've been able to advise on the different procedures and processes and methods and whatnot. I've been able to actually, thank you, sorry. I've been able to do interviews, data collection, facilitating advisory group circles, trying to find Indigenous advisors to do more Indigenous engagement. Like, I've really been able to do a whole host of things. And what I appreciated about this role, like specifically, was that they geared the work that I'm doing to what my skills and strengths are. And that's really been beneficial for the relationship, to build the working relationship, and just like the rapport that we've been able to develop. So it's really important to have peer researchers for a whole host of reasons, but really because people who have been, people who use drugs, people who have been stigmatized by the system, like many of the pregnant people that we're researching, there's like specific things that we know that might not, like, that researchers might not think about on the day-to-day basis. Like, a lot of times when people bring data to us and there's numbers, we need to be able to find the stories behind those numbers. And that's where the people with lived experience and peer researchers can really come into play and help advise on those things. But yeah, it helps build trust. Peer researchers can bridge a gap between the research team and the community. So it's not just like building trust in the team, but building trust with the community and the research participants. For participant recruitment in and of itself, I think it's easier for us to help with recruitment and just like share ideas about where people are and how we can reach people in more accessible ways and that kind of thing. We have specific networks as well that we can kind of tap into to get some of these projects done. The peer researchers also facilitate advisory group meetings, and I conduct data collection like interviews or storytelling interviews, so people feel more comfortable sharing information with people like us more. We have less judgment, there's less fear of stigma, and like there's no shame, and we can have like open and honest conversations, and that's really helpful for people when they're trying to share their stories and their voice. We also have very unique insights and a better understanding of the context in which we're like working and researching. And then there's also like a two-way reciprocal relationship happening, because when you are able to do these things and start making a difference in other people's life and start helping other people share their stories and amplify those stories, I think that provides purpose, and you see the impact that your work has, and that helps fuel you to do more advocacy or more work in the area or more research, and it really helps to keep that machine going. So I think it's really important to have like a very purposeful and like a really purposeful and thoughtful two-way reciprocal relationship, so that people do achieve healing through the work of helping others. It's just like part of what being a peer researcher is about, for me at least. And it also helps the community, because we can share those skills and that knowledge of how things work and how the work is done with others, and then it spreads that way too. So yeah, next slide please. So this project was designed to be informed by the community to ensure that it's relevant and useful to the community. So one of our main engagement activities is with advisory groups, which we have 2 of. We have people with lived experience, and we have lived and living experience, and we have knowledge users who also work across 5 provinces. This includes addictions medicine physicians, social workers, public health practitioners, program planners, decision makers, and we decided on an integrative engagement approach, meaning that we are consulting with those advisory groups throughout the project and research cycle, which you can see in the diagrams. We kicked off the project asking about the members' priorities in the area and understanding how we could make this project useful for the knowledge users. We continued meeting with advisory groups to discuss the findings, to co-develop recommendations, and co-create knowledge translation products that are tailored to fit the audience's needs. When forming those advisory groups, we started with internal criteria. We were hoping to invite people with different types of opioid use living across all 5 provinces. So it's important when inviting people to participate or in an advisory that you're clear on like what the role is, where the meetings will be held, how long the term is for, how much people will be compensated for their time. And then when working with underserved groups or like, yeah, people who are marginalized or people who have lived experience, it's important to budget for, especially with this population, childcare, disability accommodations, and those kinds of things to remove equity barriers so that they can participate in meaningful ways. Because it's really hard to find people to engage in the ways that we need. So peer researchers can also be helpful to identify potential advisory group members. We also can help facilitate those meetings. I think when you're having an advisory group, it's important to have someone who's part of it help at least co-lead it, co-facilitate it, and help plan the activities, because the groups just come out better and the meetings just are more, I don't know, relevant to the people who are at them. So we can go to the next slide now.
So we also use consensus methods to determine which surveillance indicators we would feature. So there was a few phases with this. We started with an environmental scan. So we looked at peer-reviewed literature and the gray literature, and we came up with 61 candidate indicators. And then in phase 2, we conducted a 3-round Delphi study with 14 knowledge users. So we took these candidate indicators and we put them into an online survey, and participants were asked to both rate them in terms of how important they were to be measured, and then also rank them as well. So we can use that for indicator prioritization. So we had 2 different online surveys. People could also suggest indicators that they felt were missing. And then we held an online consensus meeting where we discussed indicators that didn't meet consensus. And then Ashley was involved in phase 3 with the qualitative interviews. So I'll turn it back over to her for that part.
So for phase 3, it focused on engaging people with lived or living experience of perinatal opioid use, to bring their distinct and valuable perspectives. We opted for qualitative interviews as opposed to a structured survey process so that we could, you know, really hear people's stories and experiences. Sorry. We had 60-minute interviews with 9 participants, all with lived or living experience. And those interviews were conducted by a peer researcher like me, and a member of the research team, Reshma. So, following coding and thematic analysis, we identified 7 key themes, 4 relating to maternal health, 2 to child health, and a cross-cutting theme of stigma. Navigating pain and opioid use in pregnancy was one. So for many participants, opioid use often stemmed from physical and emotional pain. Many people tried to reduce or stop opioid use after learning about pregnancy, but lacked information on the harms of perinatal opioid exposure and risked going into preterm labor. Participants struggled to navigate decisions about opioid use during pregnancy while parenting, especially given lack of agency in decision-making and limited guidance from providers. There were structural vulnerabilities, so mental illness or health, racism, and housing instability shaped health and parenting experiences. One participant talked about receiving better supports while being incarcerated than they would have otherwise. There were also themes of power imbalances and mistrust in healthcare settings. So many described feeling stigmatized, misinformed, re-traumatized, especially during labor, delivery, and postpartum care. Postpartum especially, many people described having resources like mental health counseling stripped from them following birth. There was like a complete disconnect with like service providers once they did give birth, and there was really a focus on the child now instead of like a holistic approach. So we also found themes of reclaiming agency through advocacy. There were stories of resistance, self-advocacy, and peer leadership. Some participants actively pushed against stigma and institutional bias so that they could protect their families. Some worked in harm reduction or advocacy roles to support others facing similar challenges. There were also themes about like child health. So participants had concerns about the long-term health of their children, especially related to developmental and neurological health. Participants also reflected on access to pediatric or early intervention services, which were often delayed and up to a year-long wait times. And there was like a underlying or cross-cutting theme of stigma. So there was a persistent and harmful force throughout the interviews stigma was a persistent and harmful force throughout the interviews, impacting participants' healthcare experiences, their self-perception, their ability to access services, and even like the way that they saw themselves within those services. And I found that there was a lot of like self-blame, self-judgment, and yeah, blaming oneself for whatever issues they were perceived to have. And then if we can go to the next slide. We mapped indicators into themes where available, and then included those indicators in a final consensus-based core indicator set. And yeah, the indicators were maternal chronic pain, duration of prescription use, opioid use during pregnancy. For structural vulnerabilities and perinatal health, the indicators were involvement in criminal justice system, a history of homelessness, First Nations, Métis, or Inuit identity, rural and remote residents. For power imbalances, mistrust, and need for trauma-informed care, the indicators were prenatal care received. Reclaiming power through advocacy and peer support, the indicators were that infants were discharged to social services or child welfare. And then around the child health concerns, there were emotional health and maturity indicators, language and cognition indicators, and overall child development indicators. And when talking about barriers to pediatric and early intervention services, the indicators were neonatal abstinence syndrome, treatment of newborns with neonatal abstinence syndrome, and developmental screenings. So we can go to the next slide, I think.
Thanks, Ashley. So as you can tell, there's several indicators. I'm not going to go through them all, but I do just want to point out that there are different types of indicators. So for example, if you can just touch the next button, a little highlight should show up. Thank you. There are some, so type of opioid use, for example, is really useful for understanding the prevalence of prenatal opioid exposure and the different types of opioids used. So this could be useful for public health unit resource planning. And then if you look at, say, social demographics, health conditions, and psychosocial variables, this can really help to get a better understanding of the intersection of co-occurring conditions, social factors, and demographics. So these variables can be really, or indicators can be really helpful when you're thinking about planning integrated care. So you can look at different co-occurring conditions and see the different types of services that should be offered. Next slide, please. And then for child health indicators, we also just wanted to show you an example of an actionable indicator. If you can just click the next button, there should be a highlight that comes up. So in the context of a universal healthcare system, there's some indicators where you can really see some gaps. So if you look at preventive pediatric care, such as well child care visits or developmental screening, you can see large gaps and disparities in who's receiving these services. So it's just a really clear indicator that more work needs to be done to reduce the gap. Okay, next slide, and we'll go back to Ashley for storytelling.
So we received, so many times researchers come to me and have data, and like it says bits of the story, but it doesn't tell the whole story. And we have to use stories to kind of fill in the gaps so we can see the full picture of what is happening. So we received funding from the Leong Center at U of T and Sick Kids to conduct a storytelling project. We designed the story arcs using a strengths-based approach. And we used the 7 grandfather teachings to guide the questions. These stories are going to be featured on our project website and on the dashboard that to encourage people to think about the people behind the numbers, to increase awareness and compassion, break stigma, and highlight the strengths of people who use drugs in pregnancy. And yeah, the one thing I heard in a lot of the interviews was about what people wanted in a dashboard. They said they wanted things to show them that they weren't alone. They felt very alone during pregnancy and felt like they were like very isolated in their situations, and wish that they could have stories like Mary's available so that they could know they weren't alone. So if we could play Mary's clip, that would be wonderful.
It's for people who are addicts, this is a life-saving medication for us. This is a medication that can give us back our lives, and yeah, we might have to take it forever. Some people don't, some people do. But we take pills for our hearts when we have heart problems. We take pills for what, when we have problems, if issues in our bodies. Scientists create these medications so we don't have to deal with that. We don't have to live with the constant threat of a heart attack every single time we get excited or whatever. And it's a medication just like any other life-saving medication. It really is.
We'll also be producing infographics and social media posts with highlights from the dashboard. This is just an example of a info sheet we produced with one of our advisory members and provincial colleagues on the opioid toxicity and death in pregnancy and postpartum. So you can see notable increases in non-fatal opioid toxicity in the dark green. It increased up to 220% during the pandemic. Deaths from all causes is the light green line, and opioid toxicity deaths in the postpartum period is the red line. We also included quotes from our advisory group for context. Next slide, please.
So one of our main knowledge translation products will be this dashboard. So it'll be available on our project website along with technical documents and some of the infographics that we have planned for people who aren't interested in clicking through a dashboard. So it'll be open access, and we're hoping that this dashboard really starts to address some of the knowledge gaps and will start to increase awareness about prenatal opioid exposure in Canada. You'll be able to focus on Ontario, but also comparing indicators across provinces. So I think this will be really helpful for public health units as well. I know from my epi days at Toronto Public Health, one of the most common questions we had at the Board of Health were, well, how do we compare to other jurisdictions? So I think that the dashboard and having the other provinces' data will be really useful for public health units. So we initially created the opioid indicators, and we actually brought this dashboard back to our advisory group with people with lived and living experience. And we asked people to complete a set of tasks, and then we had a meeting to discuss the user experience and the functionality of the dashboard. So we did receive feedback on it, and I'm hoping we can share the dashboard. So while we're doing that, thank you. There's a full screen button at the bottom of the dashboard. So right now the dashboard, or I guess when it launches, we hope to launch it mid-November. So we will have some media and some notices going out to keep people posted. Right now, the dashboard features Ontario data, but as other provinces' data starts to come in, we'll be updating the dashboard as well. So this is really just a landing page. We're hoping people can easily do kind of a cross provincial comparison here. There's, for people who aren't familiar with Tableau, there's something called a tooltip. So if you hover over, say that Ontario graph right now. So we've used these tooltips wherever we can to be able to provide either interpretation of the data or to give a little bit of background. So you can see as you hover over, but the numbers are changing and you can really see what any prenatal opioid exposure looks like in Ontario. So by the end of the study period, I think it's 2023, it's down to around 3%. And then overall, when we look at the last 10 years, it's around 4%. And then at the very top, you can see the yellow bars. That's the navigation pane. There are several different dashboards. We're trying to make this, I guess, as usable as possible for a number of different audiences. So you can click around through the top in the navigation pane. But if you click on type of opioids, for example, so in this one, when you hover over any of the different categories of opioids, you'll get a bit of a description. So we have things like short-term analgesic use. So that would be a cumulative total of 1 to 29 days covered in pregnancy. There's long-term, so you can see people who used opioids for pain management for 30 or more days in pregnancy. And then looking at some of the OATs. So you're able to interact with this dashboard. You can filter by type of opioid, and you can filter years. If you click on maternal factors, here you can see there's a lot going on, but you can also reduce this as well. So you can start taking away maternal factors, you can take away different types of opioids, or you can just compare across. So in the grant with PHAC, there was some interest in exploring the intersection between opioids and different priority populations. So in the majority of these dashboards, you'll also be able to look at what prenatal opioid exposure looks like among people who have chronic medical conditions, disability, and mental illness. So just for the sake of time, I think we can close this, but we'll have a how-to document, and there'll be a number of supporting resources on the dashboard, which will live on our project website. So we just wanted to comment on Indigenous health. So we're aware that Indigenous communities tend to be disproportionately affected by prenatal opioid exposure or use. So Dr. Astrid Gutman and a wonderful team has been doing a lot of work in this area with 13 First Nations in Ontario. So we respect OCAP principles, and I guess our approach with this project is really to be engaging in relationship building with First Nation, Inuit, and Métis communities, in hopes that if there is interest in participating and doing something similar, that we can then support these communities with technical expertise to be able to do this project with Indigenous data. And I think we will end there for questions. Thanks.
Thank you, Andi and Ashley, for that very insightful presentation. I was really struck, delighted to see how much work you've done on the engagement with your knowledge users, and particularly those people with lived and living experience. I think that data is so rich and has really, bolstered this project and the importance of it. So thank you so much for that work. We will now move into the Q&A segment to answer questions from our live audience. A quick reminder to everyone, if you have not already, please enter your questions in the Q&A pod. And there is a very burning top of mind question that I had, and I know that our audience had, which is, are there any plans to display data at the PHU level?
Oh my gosh,
Or
sorry.
even more regionally in Ontario? Our health unit in Northern Ontario always is much different than the province overall for opioid-related indicators. And people are also asking about, any municipality, region, and so forth.
Sorry, so we had some technical difficulties. I had to give up control of clicking through the dashboard, but yes, so there is a map tab that breaks out the indicators by PHU. So where possible, we will definitely include those indicators. Right now, they have the opioid indicators, but eventually we'll have health outcomes as well that are mapped by PHU. So I think where we're not limited by small cells, we will definitely have that information available.
Excellent. Our next question is, will you collect information about the types of care provided to mother-infant pairs? In particular, will there be information available about care services that maintain mothers and infants together, either as inpatient or with community-based care or treatment?
So it's a really great question and very important. So we're using existing administrative data for this dashboard. So unfortunately, we're limited to what is already collected. And I don't believe we can look at things like rooming in and those kind of practices. I will say that where there's a notable limitation of admin data, I think that's where our engagement activities come in, and we can start engaging more with communities, holding different meetings, and finding out more about that from actual people with lived experience.
Thank you. Quick question. Well, when will the dashboard go live?
We are hoping it will go live the middle of November. I believe around the 17th is what we're aiming for.
Excellent. And is there an interest in continuing to recruit cohorts in the future? i.e., would the project have another data collection period in the future?
So updates are planned for this dashboard. We ambitiously, I won't actually tell you how many updates we thought we could do in 3 years. But yes, like we're definitely thinking about sustainability, and the goal is that this is something that will continuously be updated. It really just depends on the different provinces and how long it takes to be able to access data. But yes.
Wonderful. Well, I have a question, as I see we've answered all in the Q&A pod. So this is a more methodsy question about your Delphi process, because I know in public health and myself, we're always interested in getting indicators that are relevant to our knowledge users. What was the prioritization criteria that you used for some of these indicators?
So we asked people to both, like using a 9-point scale, to both rate how important the different indicators were to understanding opioid use in pregnancy and people who use opioids. But then we also asked people to rank within each section. So within like demographics, what are the most important variables? So that's the process we've used for prioritization. And I think that it's just going to differ basically depending on what the objectives are for different projects, but that's what we're using.
So you rank them within sort of the grouping rather
Yeah.
than saying, you know, this one is a 9 on importance or a 8 on data availability.
Yeah, so we can actually use both. So the slide that I showed with the indicators, there's little percentages and brackets, but they're also listed in order of their importance. So you can look and see like, oh, this was rated to be highly important, and it was the #1 ranked indicator when looking at, say, child health variable or indicators or something. So you can look within the different categories.
And was data availability like part of that as well?
No. So, well, no. So we wanted to be able to talk about what indicators were important, regardless if we could access data on that, just because I think it's important that we're striving towards something as well, and not just saying like, you know, we don't have access to that, so we're not going to look at it. And I think that there's other ways too, like one of the first advisory group meetings that we held, people with lived experience, they had certain priorities, and we aren't able to look at those in admin data. But instead, we're going to do a qualitative paper. So I still think that they're important to know that we should be measuring these. We unfortunately can't at this time, but hopefully, as you know, data infrastructure kind of develops, then we can start looking at other indicators too.
No, that's fabulous. And I think now that you've done this really important groundwork, especially with Ashley's work with the interview, to understand what is important to the people who this data is about,
Yeah.
that then health units, for example, can advocate for their own local area to collect data specific to those indicators. So it's wonderful work and very important to highlight where we don't have data. One last question in the Q&A pod is, do you have any indicators on surveillance data quality to help understand triangulate interpretation?
Yes. So there's some indicators that are from like ICS derived databases. So those all have validation papers. We've done some work as well trying to triangulate and figure out if we can measure unregulated opioids in admin data. So we've looked a bit at that as well, which shows some base validity. We haven't like formally tested the validity of it. But yes, so some of the indicators do, and we'll have links to like validation papers as well. Did I answer that?
Yes, I think you did.
Okay.
Thank you so much. So one more question.
Okay.
Thank you for the presentation. The themes identified through the qualitative interviews were very interesting. I'm wondering if there's a plan to continue to explore them to inform your policy or program planning.
Yes, for sure. So during the Delphi process, we ended up with such rich information. So yes, actually be involved in writing up a paper, looking at people's healthcare experiences, because I think that was one of the most stark findings from that is just how much trauma is caused by these interactions. And that was also a priority that people with lived experience brought up at the first advisory group meeting. So we will definitely do that. And we're also exploring other ways to work together. So the one-page info sheet that Ashley showed on opioid toxicity and death, those are hard to measure indicators in pregnancy because typically there isn't a birth. So if there's not a birth during a toxicity event, it's hard for us to measure. So that's something where community has come to us and said that they're really interested in exploring that more. So we definitely have plans to keep working together and doing more qual work. Ashley, do you want to add anything to that?
No.
Okay.
Good.
Great, thank you so much. I mean, I think that was one of the things from your presentation that really resonated, and things I have heard with our health units and the mums and babies that they work with is, you know, the prenatal experience can be so rigorous, and then mothers have their baby, and then they can't even go back to the hospital because they get told, I'm sorry, you're no longer our patient. So the switch to the concern about maternal health to infant health is something that as a health system, we really have not properly engaged with. And I think that's something that we can work on in
I
public
will say
health.
one thing
Yes.
that there's also like a disconnect, like when you give birth, sometimes like your dose, like if you're on OAT, it might be too high. So like for me personally, like getting that care and that adjustment and healthcare in the period postpartum is actually really important. And it's one of the pieces that is so neglected because women are stuck in the hospital a lot of times for weeks, maybe even months for some, because of neonatal abstinence syndrome. So it's really important that like we shine a light on some of these things and start to see what's happening, because we haven't been able to for so long.
Yeah, that's an excellent point. And as well for the perinatal mental health piece too, which I know is a top of mind for many health units. Okay, thank you both so much. As we wrap up today's PHO round session, I'd like to thank both Andi Camden and Ashley Smoke for presenting this interesting session. I'd also like to thank everyone who joined us for today's event. You can expect to receive a brief and anonymous survey for today's session. Please try to complete this to help us improve our programming. Thank you and have a wonderful day.